Those who are not speaking, please mute your microphone. There is only post test today, which will be shared after the end of the session. Good afternoon, Marian ma'am.
Hi, Vinata. Hi.
Hi, ma'am. Nice to see you. Dr. Shamali just told that like you had some trouble logging in.
I'm kind of. I'm there, but my presentation is just giving me 1 second of trouble.
Yeah, no problem. Generally, we'll be waiting. Until 3. We'll wait for 3 more minutes and start the session.
3 more minutes, I should be able to do this.
Yeah. Swati, can you just make Marian madam co-host as well?
Okay, get that is.
Madam's device is marked as Eric.
Yes, Eric Gonzalez, that's it.
Yeah.
3.
Swati?
Your name is.
Swati?
I pasted it, but where did it go?
Yes, madam.
It has to come onto the desktop. It has to come onto the desktop. Is this the one?
Yeah, you have to save your presentation on the desktop.
Yeah, that's what I'm doing. So like I said, I still think Shamli could start.
Yeah, we'll just wait for 3 more minutes. Generally, we start at 3:05. So
Okay.
Yeah, we still have 3 more minutes, 2 more minutes time.
I have to pen drive, no?
Go to D, no?
How?
To PC.
Swati?
No PC.
Yes, madam.
Can you just make Eric, Marian madam co-host?
EOD. Go to D, press D.
Go to what?
USDs.
It opened the first time, then now it's not opening. What is that? Okay, I got it. I think I'll share. Yeah, can you all see what I'm showing?
Yes, ma'am.
So is it okay? Shall I start? Vanilla?
Yeah, ma'am. Just give me 1 minute.
Yeah,
Actually,
yeah.
Dr.
No,
Smriti
I'm
can
just asking. No
still
problem. No problem. No problem.
facilitate the session. I'll just check
Yeah.
with her if she's joining, or else we'll just start off.
Okay, no problem.
So you're done?
Thank you. Thank you very much.
Meanwhile, can you just make your screen full screen, the PPT? Yeah, I think you can go back to your first slide. Yeah, sure. Great. So Dr. Smriti is just joining in just less than a minute. We'll just start off the session.
How many participants?
Actually, we are expecting 200 participants, ma'am, around 190.
Wow. Okay,
Yeah.
great. Sounds good.
But I see like only 110 joining till now, but we'll not wait for all of them to join. As soon
Yeah.
as Dr. Smriti joins, we'll just start off the session.
Okay.
Hi, Smriti ma'am, can you hear us?
Hi, good afternoon. Sorry for joining late.
Yeah, no issues, ma'am. So which try we'll start off by introducing the speakers, ma'am, and it's over to you.
Yeah.
And
So good afternoon, everyone. Welcome to the third lecture at the Basic Certificate course in Pediatric Palliative Care. I'd like to introduce today both our esteemed speakers. Dr. Marianne Mukhadan, I think everybody knows Dr. Marianne, that she doesn't need any introduction herself. She is Professor, Department of Palliative Medicine at TMC, and the medical lead at Sukoon Nilayat, which is the Palliative Care for Non-Cancer Institute. And she's also associated with Shanti Avedna Hospice. I'd also like to introduce Dr. Shamli Pujari, who is Assistant Professor at the Department of Palliative Medicine at Tata Medical Hospital. So over to you, both Dr. Marianne and Dr. Shamali. We have 1.5 hours, and we have an exciting topic on respiratory and GI symptoms. Let's have them start, and participants are welcome to ask questions in the chat, and we will all tackle them as and when we can. Thank you.
Thanks, Smriti. Thanks for that introduction. I also just wanted to add that since I look after the children's palliative care projects in Mumbai, that's why I feel a little confident to speak to such erudite pediatricians. Otherwise, it's very scary for us, because though we are very we are very proficient in palliative care, but the pediatricians are the ones who are so proficient in caring for the children. But what I think we would really love to do is to join hands with y'all. Y'all have your expertise, maybe we have ours. And in this all these 12 modules, we are hoping that we are joining hands and we are learning a lot from you, and you are learning a lot from us. And sorry, I'm using my father's computer. That's why the name is coming as Gonsalves. So it's actually Marianne Mukardan who is doing this presentation. Okay, so kind of just to reiterate that, because we are looking at patients with chronic life-limiting conditions, and that is something which we all go on emphasizing to you all. The only reason we say that is because maybe you would look at a child and his parents or her parents in a little bit of a different way. Because here, as you would have heard in the first 2 sessions, which are already over, we're looking at the quality of life. We're not looking, we know we can't cure these children. We know that they are chronic life-limiting conditions. We know that we're looking at quality of life. And therefore, while we're understanding the pathophysiology and we are understanding how much we can care for these children, we're keeping in mind always that concept of quality of life. So things which you probably would do as a routine, as a pediatrician. Maybe as a palliative care person, I would like to ask you to think about the fact that every investigation and every invasive procedure that you do you think that if this child is going towards a little later in the trajectory of the child's illness, do you think that you're actually improving the quality of life? Or maybe by doing some painful invasive procedures where you have to change the place of care, maybe you're actually doing harm. I'm not saying you're wrong and I'm right. I'm not at all saying that. I'm saying with a lot of thought and dialogue with the palliative care physicians, probably we could come to an understanding which is useful for all of us. Okay, so we'll go through some of these topics and we'll see how it goes towards the end of it. So this, again, I'm sure you must have already seen in the previous 2 presentations. As much as you want to, we want to understand the pathophysiology. But for us, the pathophysiology is more because we are looking at, yes, there are certain things we want to change, but there may be certain things which I do not want to change. So just to give you an example, if I'm treating this child of leukemia, I will definitely want to know the blood counts every week. I will definitely want to know what's the hemoglobin, because I can't treat unless I have all this information. But if the child has stopped chemotherapy, then I do not want to know what's the hemoglobin until there's fatigue, and I do not want to know platelets unless it's bleed. So in that sense, I will have to know the pathophysiology of every illness. I don't just sit across the table and say, okay, you have nausea and therefore you will take this medicine. We look at how we'll understand the pathophysiology. We will look at definitely at having a complete history and a physical examination. But how many of those investigations are needed for me to decide how I want to improve the quality of life? Which is the place of care which is best for this child? Does it always have to be hospital and ICU? Or could there be another place? We will look at how do we plan these things as the trajectory goes worse. And then we will look at the management in terms of what we should reverse and non-pharmacological. And we're always going to put that first, at least in this session, because we just want to kind of make it clear that that's as important, if not more important, than the pharmacological management. The ongoing assessment, and yes, talking to the parents that this symptom is just not going to go away all the time. There is going to be a place for instance, when I discuss dyspnea, you'll understand I can't take away the dyspnea because I can't take away the disease. But if the parent and the child both know that yes, they can still function along with the dyspnea, then I'm going to be able to help the child and parent, keep going in a very nice way. Okay, and yes, I have to be always available for my patients. Vinela, I'm going to ask you to tell me every 10 minutes because I don't have any, what to say, there's no clock around here. Okay. So I'm going to cover these 3 symptoms and I'll try to be as quick as I can because I think Shamli has more than 3. I have only 3 and therefore I'll try to cover them in a short time. So what is dyspnea? You know the definition, I don't have to tell you. But what is important is what the child is feeling. It's not that you measure the respiratory rate or you measure the PO2 and you say, oh, we need to treat the PO2, we must have a 98% oxygen. And the respiratory rate is too high and therefore I have to do something to bring down the respiratory rate. Dyspnea is a subjective symptom. It is what the child feels and what the parents feel. And therefore it is important for us to question in as an appropriate way as possible and not just to say, okay, child's respiratory rate is this much, child's PO2 is this much, and therefore I have to treat this. It's subjective. And therefore, we do, like I said, we don't look at the tachypnea or the respiratory rate, but we want to see how much the child is actually feeling. Okay. And just a little bit, probably you all know this, I'm sure even better than me, but we know that the chemoreceptor, sorry, just one second. Yeah, we know that the chemoreceptors in the brain are sensitive to oxygen. And therefore, every time there is a change in the oxygen and the carbon dioxide level, the chemoreceptors in the carotid bodies are going to make the respiratory rate either less or more. But at the same time, like I'm again saying, which is also what happens in the juxtacapillary receptors. But again, I'm saying it's how the child is taking it. It's how the child is feeling. It's about how much the child has adapted to what is happening. It's not just the rates that we are looking at. We also know that there are stretch receptors in the lung, and that also is what causes the what you call it, the feeling of dyspnea. We know that the muscles also in the chest wall, and that's why that's important in the neurodegenerative disorders. Sometimes the dyspnea is not caused by the lungs, but it is caused by the heart. And as you know, in the neurodegenerative disorders or in some of the children that we have handled who have had a fracture of the vertebral column, we know that it is the inability of the muscles to be able to contract and expand, and that is why the child starts feeling dyspnea. So this is something which I'm sure you all know, and therefore I'm just touching on it. And again, there was a reason that I put a gap over here, as you can see. And that is because I thought just give you 30 seconds to think about any causes in your practice of children who we have seen with dyspnea. And then as we talk about the management, you probably will be able to understand why we say some of the things we say. Okay. So 30 seconds, just think of some of the patients you have handled in your practice, hospital or not hospital, private practice, whatever. What are some of the causes of dyspnea in the children that you have actually handled? The list is up there. I'm not one of those people who actually believe in reading slides. So you will maybe have seen all of these things, some of these things. Maybe you have not seen some of these things, but these are some common conditions in which children have common dyspnea. Now, again, remember that we're not talking of acute dyspnea. We are not talking of pneumonia or something like that, which is curable, but we're talking in the context of life-limiting conditions, which means that there's a very good chance that there's not a very good chance, sorry, there is no chance of this child actually recovering from this disease. So when we talk, even when we have written here about the infections of pneumonia, tuberculosis, viral, like COVID, for instance, COVID-19, these are the severe ones. These are the ones where the child may not completely recover. And when they do recover, it may take a very, very long time for them to recover. And there might be some permanent damage to the lungs, which has taken place during this long course of the illness. Okay, so all of you have got one picture in your mind of one child, maybe imaginary, maybe real, that you can imagine how that child is feeling, and you can imagine how the parents are feeling when this child is so very breathless. So this is my example. This child was admitted to us in the Sukunilaya. He was 16 years old because we don't actually take children. But since he was over 12 as IAP sorry, or not over 12 as IAP, but over 12 as in the municipal hospitals, we took him in because he kept having recurrent attacks of pneumonia caused by his aspirations because of his neurodegenerative disorder. And the last admission was in an ICU of one of the municipal hospitals where his breathlessness was becoming worse. But they treated aggressively. They gave him antibiotics. He got better with all the active care. And then we were asked to help out. What should we do with this child? So we had a meeting with the family. We had a meeting with the pediatrician, with us, with the parents of this, sorry, not parents, but the mother of this child, because the father had passed away. And knowing that it was a new neurodegenerative disorder, we thought that if we took this child in for 15 days, we could help the mother to understand that this is going to be something which is going to happen recurrently. And ultimately, this child could pass away. And we felt there was a lot we could do, not only physically, but psychologically, socially, spiritually, to be able to help her and her sister who was helping her to understand the situation. So we admitted him for 20 days and we helped her holistically. So I'm going to be talking a little bit about that holistic care. I'll give you lots of examples of what we would have done physically. I'm sure you're much better at it at that, but we will be emphasizing on that holistic care. So he had to go home because his mom had another child with the same problem and she had to take care of that child also. They also had a sister, but the sister was fine. So we needed to send them home. We needed to empower her to feel confident to take care of this child, which is what we did. We found the child also felt that the mother and sister, auntie would just not let go of him, give him no independence. We thought that, okay, we also need to help the mom to give him as much space as a 16-year-old child needs after he goes home. Okay. Again, 30 seconds. Think about how you would manage a child like this. Okay, so probably when you are assessing the severity of the dyspnea, I don't know whether even I use all these scales which I'm showing you over here, but these are the recommended scales for children. The BOG scale, which was modified then to make it a little less complicated, and the anyway, because I can't see the top of the screen, Dalhousie, the Dalhousie scale, which is pictorial and supposed to help the child to tell us how much is his difficulty in doing activities of daily living, how much does he feel constriction in his chest, and how much does she or he feel constriction somewhere in the throat. As a pediatrician, you definitely want to know the respiratory rate, the PO2, what is the, is he anemic or not? Do you need any chest x-rays? Do you need CT scan, MRI? As a palliative person, I would say, let's only ask for something which is going to help us in taking decisions regarding improving the quality of life of this child. Okay, so keep that in mind. I also would like to very much emphasize that it's not just the physical things that we need to look at, but we have to look at the psychological side. How is the child coping? What does the child know of the disease? Has anyone explained to him his questions, giving him answers to her or his questions? Putting the child's knowledge and the parents' knowledge together, first understanding what the child feels, knows, wants to know, understanding what the parent knows, feels, wants to know, putting them together in the same room so that they are on the same page, breaking all those communication barriers. You're going to be having a session on breaking bad news, so that's why I won't get into that. The question is, how normal can we help this child to be? And what kind of quality of life can we give to this child? And of course, the family. Parents are suffering, siblings are suffering. We have to take into consideration the holistic care for all of them and try to see how much of this can we solve, and the things we can't solve, how much of this can they adapt to, and how much can they continue as normal a life as possible in the midst of all these sufferings, including the spiritual, which is why me, why did this happen to me, what have I done wrong? I've always been an upright citizen. I've always done good for my family, for my society, and I really don't need this to happen. What are the support systems that the parents, child, family have where they actually live, and how can we improve that? So these are some of the things which we need to be looking into. So in the management, as I said, first I'm emphasizing on non-pharmacological. So I have, if the child is fatigued because of the anemia, yes, I will definitely correct it. But I won't correct it because the hemoglobin is 8. I'll correct it only if the child is feeling fatigue because of the hemoglobin of 8. Similarly, for the tapping, if it's pleural or pericardial, it's not that simple if the child is very sick in the home, and therefore I will take a call. If I do it, is it going to benefit this child or not? So that's always the quality of life which matters over here. Okay, so I'll correct only the things which need to be corrected. We also know that by stimulating the sensory branches of the facial nerve, we can help the patient to feel a little less dyspneic. So fan or just even a hand fan or cool breeze coming in, a room which is not too dry and is not too cold. If the room is cool but not hot, and there is enough of moisture in the room, sometimes we ask them to put some steam into the room to make it a little moist, because that helps the child to breathe a little better. Spacing of activities, as in this is a dyspneic child we're talking about. So if he's going to have if he's going to brush and go to the toilet, he's going to get dyspneic again. So he needs to have a break. Once his rate is under control for her or him, then have a bath. Again, child is going to get dyspneic. Again, the child needs a break. Again, when the child is able to do what the next activity is, he should be allowed to do it. At the same time, he should be allowed to play, he should be allowed to meet his friends, he should not be isolated, because all these things really matter to children especially. If he is infected, for instance, in COVID-19, yes, we would not want the children to meet each other because he would infect someone else. But otherwise, the child needs to be as normal as possible, can even be allowed to go to school. We do teach the breathing and relaxation techniques even to children who are able to do it, especially when they get panicked, when they get dyspneic. They need to learn how to do the yoga and meditation exercises when they're not in a panic attack. And whatever else works for the family also to relax, like Reiki, meditation, for the mother especially of this child I talked about. If there is a cardiac issue, you might need to restrict the fluid. Again, it depends on the select case. Oxygen is very debatable. It's very easy to have a concentrator, to have an oxygen cylinder in the house. All those things are so easy to arrange. But we don't want the child hooked on the oxygen. Again, remembering that these are chronic life-limiting conditions. And therefore, we will ask them to use it as less as possible, not to interfere with the quality of life. Now, talking about this child, I also, because of the fact that he used to aspirate very often, I was talking to Dr. Leena, who's in Canada right at the moment, and she reminded me that, see, we used to, whatever liquids that he needed, we used to make it into a gel, and then he would be able to swallow it much better. And that kind of helped us to prevent a lot of further aspirations. So I could probably use all the time talking about the role of ventilation, but I will just allude to it that there's plenty of evidence available now talking about non-versus ventilation versus invasive ventilation. And since we know that non-invasive ventilation can be done even at home, we need to have that debate. We need to talk to the families about what are the advanced care planning in place, what is it they want, what are the goals, what are the aspirations, what is realistic, what can happen, and then we should take that decision. Okay. Pharmacological, I really don't want to talk much about it because I'm pretty sure that you all know how to treat dyspnea in children much better than me. The role of bronchodilators, the role of steroids, the role of infections, not treating with IV antibiotics every time, remembering that not all fevers are infective. Use the oral route as much as you can and only admit when it is imperative. Role of opioids, I'll discuss a little further because we use it more in the end of life. But it is very important to remember, most pediatricians think opioids not for children. It is one of the best drugs for severe dyspnea towards the end of life, which I will again allude to. But remember that opioids and benzodiazepines in the dose, which I'm sure you already know, are the best way of treating severe dyspnea in chronic life-limiting conditions. Okay, so we know that it does not affect the respiratory rate or the effort. It does not change the PO2. It acts on the J receptors on the bronchus, and we should also remember to start with a very low dose. So this is not the opioids for pain. This is a very low dose. I've given the dose over there. I'm sure you all will understand that it is a very, very low dose, and it has been studied, and there is some evidence to show that you can even use it in the nebulizer form. Okay, So as I was alluding to the end of life, we know that this is an irreversible condition. We know that this child is not going to make it. We are not treating something aggressively because there is a good chance the child is going to be cured. We're not treating someone who even has a 5% chance of being cured. No, we're talking about this chronic life-limiting conditions where this child has no chance of being cured. We've taken the child and family through the trajectory of the illness, and now we have come to that place of end of life. Okay. So again, you've seen the non-pharmacological, so I'm not going to, I'm just telling you it's the same as what you saw in the earlier part of this talk. Morphine, again, I told you where it acts. It also acts on the brainstem, low dose. Every 6 hours, you can go up to even 4 hours if you need to. But by going on increasing, there is usually a ceiling by which it doesn't work any further. And yes, I've given some of the drugs. I think you will probably know better than me. But as I said earlier also, morphine and anti-anxiety drugs. And we've had a lot of experience with this. So I can really tell you that from practical experience that it works. Okay. And let's not forget the holistic care for these children. Okay. So cough, again, one of a difficult symptom, because we're talking of quality of life, we're talking of life-limiting conditions. So it's either something in the trachea or the bronchus or the bronchioles, or it is something which is irritating at the periphery, like say a deposit in the pleura, which is before it becomes a pleural effusion, and it is causing a pleural rub. It's irritating the pleura, and therefore this child is having dry cough because of the stimulation of the vagus or the glossopharyngeal nerve. So again, example, it's very common in osteogenic sarcoma to have lung mets, and if those lung mets are somewhere where it's going to irritate the pleura, then this child is going to have a lot of dry cough, and it was affecting this particular child in anything that he wanted to do, and therefore he was getting more and more psychologically also disturbed, away from his family, not willing to meet with anybody, because they would think that, oh, he has tuberculosis or something infective to others. Parents of his friends would not allow them to play with him. Again, his 15-year-old boy, he also had why me questions. His parents had why me questions, emphasizing that the suffering is holistic and we need to take care of each and every aspect of this social, psychological, spiritual suffering along with the physical. So again, what's the quality of the cough? What is, very importantly, what are the exacerbating or relieving factors? Because if we can relieve something, we need to relieve that. If we can remove something which is exacerbating, maybe it's the smell of the cooking, small things, then maybe we need to think of that. Maybe the child is going to school and the classroom is on the 2nd floor and he was ready to jump up the steps, but now he needs a lift or he needs a wheelchair. Maybe he has not been taught. I'm not sure whether you can see me, but this kind of a position where the patient can rest on the hands, and that gives help to the intercostal muscles. So for dyspnea and for cough, the way that the child sits or sleeps makes a very big difference. And yes, what are the medications he's already taking? What are the medications we need to change? Sometimes we are very happy giving a diary to the child so that he could write, or his parents could write, what causes the dyspnea, what makes it worse. Then we can look at the diary and see how can we make it better. Think of what is the disease, how far is he in the treatment, is he going to get better or not. General and local examination, all these things, as you are doing it routinely in your practice. Abdominal causes, yes, we have to see whether there's something in the abdomen which is pushing the diaphragm or irritating the diaphragm, and that's what is causing the cough. And we need to emphasize on the holistic approach, and we also need to emphasize on our clinical acumen and not ask for investigation if the child, especially if the child is going to find it difficult to go for an X-ray or a CT scan. So again, when we decide the management, let's have that family meeting. Let's see with the physician and the palliative care, with the pediatrician and the palliative care expert and the parents, where are we in the trajectory? Where do we wish to keep this child to be as happy and have the best possible quality of life as possible? What is the child and family's wish? Where will they go for end of life? All these things need to be discussed way ahead of time. Again, like we said in the dyspnea, Whatever you think you can reverse, please go ahead and reverse it. Use the non-pharmacological methods as much as the pharmacological. Dextromorphin and morphine are very useful. Codeine, as you will find on the labels of the codeine bottles, will say not recommended in children. But we have gone into this in very great detail, and we know why it is not recommended in children, because it's not tested in children. So we need to go very much into the depth of some of these drugs which are not recommended in children, and see whether we need to figure out what is the harm. Because some of the things which are written as not recommended in children, they may be long-term side effects. We are talking of chronic life-limiting conditions. We need to expect how much more time we assume this child has, and accordingly, if we're not harming the child in the present, and we take the family into consideration, then there are many drugs which you can use as what we call off-label use. I'm not saying you should do it. I'm saying this is something we should do more and more research on. And when we need to use that, we will look at the actual side effects and whether it's safe in this particular child. So it's not long. We're saying, what I'm saying is, don't look at the long-term side effects, only look at the short-term side effects. Take the help of colleagues, take the help of your seniors. Once you've decided that, yes, I would like to use this drug, it's not going to harm this patient of mine, then take the parents into conference and then start using it. And again, just like dyspnea, you need to have anti-anxiolytic drugs as well. Third symptom that I'm covering in a short way is about secretion. So when the child is reaching the end of life, or especially in these neurodegenerative disorders, and sometimes even in cancer, the child is unable to cough, and therefore the secretions get stuck either in the trachea or in the bronchus. And because the child is not able to bring it out, you have those sticky secretions, because basically what happens is even the hydration is less, and therefore those secretions are very sticky, and the child is unable to bring it out, and there's that death rattle kind of sound, and that really disturbs the family more than it disturbs the child. Find out what's going on. I mean, as in, what medications are they drying up the secretions excessively? How much is the hydration? Is there something in the cause that we can reverse? See whether changing the position of the child. Even I read one of the papers just recently where putting the child in the knee elbow position helps in bringing out the secretion. So maybe after you do the nebulization, you put the child in the knee elbow position for a while, just to see whether some of those secretions will drain out. These are all things we need to do on an individual basis. Look at the holistic suffering that even the parents are feeling, hearing these sounds, and then deciding on advanced care planning. And in the management, most of this is already covered in the other two symptoms. So we'll use whatever we think we can use, which will actually improve the quality of life of this child. And in the drugs, there are drugs which cross the blood-brain barrier, which cause a bit of sedation, but then they have a role, and therefore I've listed them here, like hyoscine hydrobromide, which is known as scopolamine in the Western countries. There is a role for using atropine, and since eye drops in 1% solution are very easily available, they can be given sublingually, 1 drop every 4 hours. Okay. And then the hyoscine butyl bromide, which is not as effective, but it is something which, when you don't have anything else, you can still consider hyoscine butyl bromide. These drugs cross the blood-brain barrier, and therefore they can cause a bit of sedation. Not saying it's bad for our children. It just depends on where we are in that trajectory of the illness. Glycopyrrolate, more expensive, not orally available, but still it is one of the best drugs which we use for excessive secretions. Okay. So I think that's all I want to talk about. So I'm just saying, for my part of the talk in respiratory symptoms, we should always look at what is causing the symptom and then try to treat that. Reverse only when it's relevant. So like I told you earlier, I'm not treating the hemoglobin of 8. I'm treating the fatigue which is caused by the hemoglobin of 8. I'm not treating like low platelets. I'm treating the fact that when the child goes to brush, or when the child passes urine, there is blood in the stool. So then I will definitely treat the low platelets and bring it up with the platelet or whole blood or whatever. Okay. So in that, we need to take into consideration, where are we going to take care of this child, not only in the present, but also in the future. How long do we think this child is going to live? Discuss those advanced directives. taking into consideration the wishes of the child and the parent, and therefore plan where we are going to treat, how we are going to treat, what are the non-pharmacological, what are the pharmacological, because our aim is to provide the best possible quality of life and death. Okay, and I think this is also pretty similar. So I think we also, some myths, I'm not a pediatrician, sorry, but I know that when we first started pediatric palliative care in Sion Hospital, Sion Hospital, the biggest burden we have, and we still have it, is that in Sion Hospital, morphine is still not available in the Department of Pediatrics. Why? Because it's a bad drug, it is addictive, it should not be used in children. So these are some of the things which we need to research and look for evidence and think about it. Okay. Second myth, children are safest in the hospital. Parents also feel the same. They're very scared to have patients in the home. There is a place for hospice, no doubt, but I'm not recommending hospice as much as I'm recommending home. But to make the home a safe and a quality place for the children and their families and the siblings, because then the siblings and the child can also be together, we need to make sure that we give the right arrangements. If our arrangements are not good in the home, if the home doesn't have their assistive devices which are needed, if the home doesn't have a local GP where they can call on that doctor at any point of time, if there is no recourse to other things which they might need, if there is no phone number given where they can call you or your colleague at any point of time, if all those things are in place, I think of all the experience we have had with home care in the last 20 years, I think that even for children who are dying, it is still the best place for the parents to take care of the child. But of course, as I said, you need to have all these things in place. Okay, so I'm going to hand over now to Shamli. Thank you very much for your patient listening. I'm still here. So at the end, if there are any questions to be taken in the chat, we'll be happy to do that.
Thank you so much, ma'am. Can you see my screen?
Yes, we can.
So the next part is management of gastrointestinal symptoms.
Do slideshow.
Yep, thank you. So objectives, basically, you need to understand what symptoms the child might face during their last few days, months, and weeks of life. The pathophysiology of those symptoms so that we can manage them accurately, how to diagnose them without doing any aggressive interventions and investigations, pharmacological management, and like Mukhadan ma'am emphasized, the non-pharmacological managements of these symptoms. So a study done in 2021 on patients in children who receive palliative care at home showed that these are some of the symptoms that are seen in last few months, and then the darker one is in last few days, that is last 7 days of life. So you'll see the most common symptom is anorexia, cachexia, followed by constipation and followed by vomiting. The diarrhea is there, but it usually goes away towards the last 7 days of their life, and ascites is like in less than 1 to 2% of these children. We need to know what are the steps of managing these symptoms, because you don't want to give multiple medicines for the child. The child will not take those medicines. So you need to establish the cause so that you can treat that. Reverse anything that is reversible whenever possible. This doesn't mean that you have to get aggressive while reversing things, but anything that can be reversed without going aggressive, you need to reverse that. You need to choose the most appropriate receptor antagonist so that like you are not giving multiple medicines again. Choose the most appropriate route of administration. So not everything has to be IV, not everything can be oral. It depends on where the child is cared for. If the child has come to your outpatient clinic, or if the child is admitted in hospital, or if the child is in hospice, or if the child is at home. So your route of administration will change on these scenarios, as well as if the child is actually able to tolerate anything orally or not. If the child is conscious enough to have oral medications, or if there is any risk of aspiration in that child, you cannot give orally, then the child does not have IV access. So what will you do now? when you cannot give orally and when you don't have an IV access. We forget that we have something called a subcute route that we can consider for most of our medicines. Or buccal route, the simplest thing. You don't need a nurse or a doctor for that. Or per rectal route, wherever possible. So you need to think in that way also when you're prescribing any medicines in palliative care setting. And you need to review regularly. Like ma'am said, the parents should have a contact number or someone that they can call in and check in. So these are my symptoms. It has got relieved by 60%, 40%. Should I stop the medicine? Should I reduce the dose? Should I change it now? So you need to review those prescriptions regularly so that you're not overdosing or underdosing that child. Something that we follow, we treat the cause wherever possible. If that is not wherever possible, you always treat the symptoms, and you definitely treat the experience, because if you don't do it in a complete way, it does not really help the child or the family. Coming to our symptoms, so starting with nausea and vomiting, nausea is an unpleasant sensation of needing to vomit, and vomiting is the forceful expulsion of gastric content through the mouth. Now, nausea and vomiting is very distressing, not only for the child, but also the people who are around the child. So the siblings, the friends, the parents. Nausea may not be that annoying for everyone else, but vomiting, retching is. So it does not just affect the child, it affects everyone around the child also. So physiology, yeah, so it may be preceded by increased salivation and beginning of involuntary retching. There is synchronous contraction of diaphragm, intercostal muscle, abdominal muscle, which causes raise in intra-abdominal pressure. This causes a relaxation of lower esophageal sphincter, and there's forcible ejection of gastric content. So, like we said, we need to treat the receptor profile while managing any symptoms. So these are some of the receptors and some of the centers that are involved in nausea and vomiting. So if you know that the child is on any medication, so like chemotherapy or even opioids, or if the child has infections, or if the child has any biochemical disturbance, electrolyte imbalance, uremia because of kidney failure, or in hepatic encephalopathy, the chemoreceptor trigger zone is affected, and the neurotransmitter involved here are dopamine and 5-HT3. So the medicines that you will prefer in such children is based on these receptors. So something like metoclopramide, something like haloperidol, and something like ondansetron. You can choose whichever is available. We need to know which of these are available as sublingual medicines, because you cannot give orally if the child is actively vomiting. So ondansetron has sprays and films and sublingual or mouth dispersible tablets, so it can be preferred. Haloperidol again comes as sublingual tablet, so you can consider that. If the child is having a huge tumor in the abdomen or some mets in the abdomen that is causing decrease in the gastric motility, or is causing obstruction, or there is hypokalemia causing ileus, paralytic ileus, or if the child is just constipated with a lot of fecalith and fecal loading, if that is the case, then you need to target the dopamine and 5-HT4 receptors. And the medicines that you can use here are again something that will have propulsive action, like metoclopramide and domperidone. Similarly, if it's anxiety and anticipatory nausea, which we see a lot in patients who are undergoing chemotherapy, benzodiazepines are something that really act well here. So how much ever metoclopramide, ondansetron, domperidone you give, it may not act as much as a small dose of benzodiazepine will. So we need to take care of that also. Again, we should not forget that these children also can have causes which are not related to the disease, like motion sickness. So child has come traveling 8 hours in bus to see you, and the child is vomiting. You don't have to get an MRI brain or CT brain done. You can just rule out other causes like motion sickness. So we can just discuss vomiting according to the cases so that it's much easier to understand. So there is this child with medulloblastoma who has come with vomiting, headache, and is quite irritable. What do you think? What can be the cause here? You can put it down in the chat or unmute and answer.
Raised intracranial tension.
Raised intracranial tension. Yeah.
Perfect, perfect. So something that, you know, when you have a known mass in the brain, around the brain, then if the child is presenting with headache, vomiting, is irritable, has photophobia, you need to rule out raised intracranial tension there. And what can we give for management here?
Steroid.
Perfect. So steroid just doesn't manage the raised intracranial pressure. It also manages the vomiting associated with raised intracranial pressure. So we are not just treating the cause here, we are treating the symptom also. And if the child is not vomiting, it also reduces the headache again. So both the symptoms are managed and the child is happy with just one drug. So steroids. Second, is a child with severe pain, started on tablet morphine a day ago, now presents with vomiting to your OPD. What can be the cause here?
Morphine itself can cause nausea.
Yes, perfect. So drug induced. So something that we tend to ignore is sometimes the medicines that we give can precipitate some side effects which are more severe than the symptom itself. So we also have to give preemptive medications to manage the side effect of the medication that you are giving. So here it's morphine-induced nausea, vomiting. It can be severe sometimes, but the patient will develop tolerance to morphine-induced nausea, vomiting. So the patient will usually develop tolerance to most of the side effect of morphine except constipation and analgesia. So you have to give antiemetic in the initial few days, so 3 to 7 days on SOS basis for the child to take so that they do not develop nausea, vomiting. Perfect. So third case is a child with liver metastasis, is icteric and now has a lot of vomiting.
Central receptor trigger zone stimulated.
Perfect. So liver cell failure. Perfect. So this is the biochemical response. So child may not be in frank hepatic encephalopathy at present, but this may be one of the symptoms because of all the ammonia that is getting accumulated. So you manage, like ma'am said, you manage some medicines that will act on the CTZ receptors and the child will be doing well. Fourth case is a child with osteogenic sarcoma. He has a huge tumor mass with wound around the shoulder and comes to your OPD with nausea. Persistent nausea.
Maybe some kind of anxiety seeing that tumor, and also chemoreceptor trigger zone stimulation, central.
Maybe you were almost right in the first part, the anxiety part. So something that we need to focus more here is this child has a huge mass with huge wound which has which has purulent discharge.
Infection.
Maybe infection. Infection can cause something which even normal people, even the nurses and doctors may not tolerate very well, especially when it's
toxicity, madam. Toxicity, toxin release.
Toxin release. Yes, perfect. Some people are writing that. Odor and the smell. So I'm not sure if you have actually seen patients with huge cancer related mass, be it a child with OGS or be it someone with head and neck cancers. It is quite foul smelling because of all the anaerobic infections that is going around and in the tumor bed. So it is really foul smelling. Sometimes so much that even we cannot tolerate it. So imagine this young child having to live with that odor continuously. And the pain associated with that huge mass. The pain itself can sometimes cause anxiety, fear, nausea, vomiting, and all the associated symptoms that we talk about. So, yes, the odor, perfect.
Why not hypercalcemia?
There can be hypercalcemia. It's not that we don't have other features of hypercalcemia. So like Mokaran ma'am was saying, we'll not investigate every child who comes to us. So we need to have at least 2 or 3 symptoms, to actually say that, okay, this can be hypercalcemia, and we'll do the investigation. So there is no constipation here. The child is conscious oriented, not irritable. So we'll not suspect hypercalcemia. You are right, it can be, but it will not be our first suspect.
And even child may be on some kind of treatment, drug related.
Yeah. So there are multiple causes that can be here in every of the case, because I've not even detailed history, but this is just to, bring awareness to the fact that even something like a foul smelling wound can cause symptoms which are not related to the wound. And we need to be careful while you take history from children specifically, because this child never told us that he is having nausea because of the foul smell. It was only after trying multiple medicines that we came to know that this is the real cause. Nausea can be multifactorial. So like we discussed, what could have been the possible diagnosis and what could have been the possible management in these cases. Like we said, you have to also look at other associated symptoms and causes of every symptom that you are managing. So if the child is having persistent cough and the child comes to you with vomiting, and vomiting after coughing, so you do not give ondansetron directly at that point round the clock. You might give an SOS medications for that, but then you have to also manage the cough part, which is actually causing the vomiting. So like that, multiple other precipitating factors. We need to understand that these children also can have other conditions. So it doesn't always have to be the actual disease that the child has. So like we discussed, motion sickness, medicine side effects, or even menses related abdominal pain. Something that we usually forget to think in these child are the allergies that they might have. So sometimes they are very small, they have been undergoing chemotherapy, and most of the times they are told not to eat most of the things that they can. And when they are under palliative care, they start eating everything that they wanted to. And sometimes some of the allergies are then seen at the later part. So we need to understand that the child may have been intolerant to some of these things which we were not aware of. So we need to understand that also. I'll just skip through these slides because, like ma'am said, you all are more expert in managing these symptoms than we are. So, focusing on the non-pharmacological management, a lot of chemotherapy and oral chemotherapy induced nausea, vomiting can be like at the slightest slight and smell of food. So we usually advise that if you're giving the child food, you have to cool it down. You don't prepare the food right in front of the child. मतलब बच्चे के घर में है, बाजू में है, तो तड़का मत दो, so that the child does not get nauseous and is able to eat at least some food. Provide small meal wherever possible. Food has to be room temperature. And if the child is not able to tolerate at all, we will try to make the food as much as calorie dense as possible. So something like ice cream, kheer. We do not really restrict food intakes here unless the child is allergic to anything. So kheer, ice cream, something which has a lot of sugar, carbohydrates, and fats and proteins to just give energy to the child. So you can add a spoon of butter, oil, ghee, some syrup, sauces to the child's food so that it tastes better for the child. Moving on to the second symptom, that is constipation. We know that it's difficulty in defecation. It has a proper definition, but I've just included a point here: infrequent bowel movements, small quantity, hard stools, and difficult or painful evacuation. So something that we usually see in our kids are these feculates or feculoma formation, because they are not as active as a normal child. They are usually sitting at one place. Some of them are bed bound. So there are restricted activity which can further, worsen the constipation. So the child has constipation, does not get any laxative, has fecal retention, causes rectal dilation, decreased sensory perception, hard stools. It is again painful defecation. The child does not even attempt. There is partial evacuation, impaction, and this feculate and feculoma formation, which can sometimes even lead to bowel obstructions. So we've very commonly seen that. That's why treating constipation as soon as possible and whenever possible is important. Like I said, most of our patients are on opioids for pain, and something that the child will never develop tolerance to in cases related to opioid is constipation. So you always have to give laxative along with any opioid. Always, always, always. Unless the child has loose stools, where you can withhold laxative for that period of time. So again, you identify the cause, rule out obstruction wherever you suspect obstruction in abdominal malignancy or abdominal lymph nodes, or even in childs with cerebral palsies where they are not able to communicate well, in any non-cancer disease. Those who are on medications, those who are on anti-epileptics, those who are on NSAIDs, those who are on anticholinergics. So these medicines usually cause constipation. So we need to understand that and manage the side effects there. First, you try with non-pharmacological management wherever possible. So increase fluid intake, dietary changes, if the child is able to do that. If not, then you'll go for proper pharmacological management. So pharmacological management, you have oral syrups, medications, and tablets that you can use, and then you have enemas and suppositories that you can use. Now we need to understand that if you're talking about cancers, if the child has severe neutropenia or very low platelet, you cannot really consider enemas and suppositories there. So that increases the risk of infection and bleeding. So you have to use the oral route possible. So syrups and bisacodil tablets, senna tablets. These are some of the commonly prescribed drugs. Lactulose. I'll not go deep into the doses because you people are more expert there. So lactulose you can use, but you need to know that lactulose causes severe bloating and abdominal cramps, and we've seen it in many patients. So we usually tend to restrict lactulose use in children who have some hepatic derangement and will require lactulose for other reasons. Because lactulose again does not really have a propulsive action. So it's not a stimulant. So just lactulose may not help in children who are under palliative care as much as it does to patients who are much more mobile and walking around. So some stimulant is always needed in our kids. So something like polyethylene glycol is preferred if the child is able to hydrate himself or herself well. Milk of magnesia and bisacodil is something that we regularly use. Again, we need to understand the complications of all these medicines that we use. Like if the child is having some renal dysfunction or some renal issues, you usually avoid milk of magnesia there because of all the electrolyte imbalance that it can cause. These complications are again for who have expected survival of months. If we are talking about days and weeks, we can ignore most of the side effects, like ma'am said. So here is a case of 10-year-old child having sarcoma of left femur, severe pain at the site of the disease. Pain was well managed by titrating the morphine dose. However, the child came back with abdominal pain and constipation since 8 days. What do you think? What did we miss here?
We didn't start the stool softener.
Right, perfect. So we did not give laxative. So something that this child now developed is opioid-induced constipation. Now, opioid-induced constipation can sometimes get tricky to manage. Most of the times it does get relieved with the regular laxatives that we give. So again, we need to add a stimulant because opioid decreases gastric motility. So just a stool softener will not work. We need a stimulant. So something like bisacodil or polyethylene glycol, which is a osmotic laxative. So opioid reduces the peristalsis, it increases circular motion contraction, reduces secretion of fluid and electrolytes, causes dry stools, causes cramps. So that's why this child has come with abdominal pain and constipation. So a specific management of opioid-induced constipation is methyl naltrexone, however, very costly and not readily available here. But in case if you have a child where nothing helps, you can consider methyl naltrexone. You really have to order it from the distributors. It's not really available everywhere in the pharmacy. But it's just a one-shot subcute injections, and the effect starts within minutes, and you don't really have to repeat the dose. I'm sorry, can you erase the line that has been made here? Sorry, I don't know who did that. So the next case is 12-year-old child with lymphoma. Thank you. 12-year-old child with lymphoma with metastasis to abdominal nodes. Came with complaint of vomiting since 5 days, constipation since 9 days, abdominal pain. Symptom is not relieved with laxative and ondansetron. What could be the cause here? Yes, ma'am, I have 25 more minutes.
Intestinal obstruction.
Intestinal obstruction. Perfect. So multiple air fluids level. Sometimes the films are not as classical as it is here, but we do see a lot of malignant bowel obstructions. There can be many other reasons of obstruction which are not malignant, so intussusceptions are common. I mean, we all will be seeing more of those, but we see more of malignant bowel obstructions. So again, principles, we try to manage malignant bowel obstruction as conservatively as possible because surgery may not be an option in patients who are with advanced illness. So conservative management involves these 9 A's. So allowing gastric decompression by using a nasogastric tube or venting gastrostomy. Again, this has to be discussed with the child if the child is able to communicate well enough, and the parents, because not all child will be comfortable with a nasogastric tube. So this has to be discussed. All the management practically have to be discussed with the parents and the child, but nasogastric tube more so because it can be really distressing. If the child is not willing for a nasogastric tube or the parents are not willing, you can start with other management. So like local acid suppressions with proton pump inhibitors. Avoid prokinetics here because that may if the child is already having colicky abdominal pain like this child had, so you'll avoid prokinetic to worsen it, or to it might just cause a bowel perforation. So you avoid it if the child already has colicky abdominal pain. You need to give analgesics here. We know that opioid causes constipation, but if the child is already in complete obstruction, you need to relieve the pain. So something that you can use is opioid again. The choice of opioid is fentanyl. Some studies have shown that fentanyl is less constipating than morphine. However, it's not a given thing. Wherever possible, we do prefer fentanyl in bowel obstruction. The other reason is fentanyl is available as transdermal patch. So if the child has obstruction, child is vomiting, you'll not be able to give anything orally if you don't have IV access, acute access. Fentanyl is readily available as transdermal patch, so can be used safely. And antiemetics like haloperidol and ondansetron. So we need something again that is not prokinetic. So haloperidol, ondansetrons are good options. Antisecretory. So hyoscine butyl bromide and octreotide and glycopyrrolate. We routinely use antisecretory for most of our patients with bowel obstructions. It also reduces the vomiting quantity, and the child is much more comfortable then. Anti-edema measures dexamethasone. So if that is a mass or cancer that is causing the obstruction, it is usually surrounded by a lot of edema. So dexamethasone really acts on that edema, the bowel edema, because of inflammation, and sometimes dexamethasone will easily reverse the bowel obstruction in some of our patients. So dexamethasone is something that we really use in obstruction. You avoid overhydration, you'll hydrate the child, but avoid overhydration to increase gut. Otherwise, it can increase the gut wall edema. And antibiotic, if required, if the child is in sepsis or has bowel obstruction because of any infection. The third symptom is anorexia cachexia, one of the biggest and the most difficult ones. What is the most common question every parent will have throughout the disease trajectory, especially in an advanced illness? Does obstruction relieve with medical management? Yes, we have really seen obstructions getting reversed with conservative management, especially the dexamethasone and anti-secretory medicines that we prescribe. But we need to understand that the disease is still there and we are not doing anything for the disease. So there is a chance of recurrence. But we can definitely provide good symptom control in malignant bowel obstruction with just conservative management. Yeah, so common question, poor intake, poor appetite. Will child eat or drink without any problem? Child is not taking any food. Yes, even we get the same question. मेरा बच्चा कुछ खा नहीं रहा है, बच्चा क्या खा सकता है? What can my child eat? Why my child is not eating? My child is not eating. That is most of the time the first question, because rest of the questions are usually answered by everyone. So this is some answer that they do not get from anyone. So they keep asking that, what can the child eat? What can the child eat? And whereas the child, on the other hand, is suffering from this illness where he or she is not really hungry, does not need that food, is not very active, does not need that food again. So anorexia is loss of appetite, poor calorie intake. Cachexia is metabolic syndrome characterized by loss of muscle with or without loss of fat. Anorexia cachexia syndrome, it involves involuntary weight loss, tissue wasting, and weakness. You need to understand cancer-induced cachexia specifically, because it's not just about not eating food. There are multiple factors involved in cancer-induced anorexia cachexia. So there is this inflammatory process that is continuously going on, especially in advanced illnesses, which causes severe catabolism, proteolysis, lipolysis, cachexia. So it is usually cytokines and inflammatory driven anorexia cachexia in cancer. And then there are other factors like poor oral care, chronic nausea, altered taste, dysphagia, odynophagia, pain, depression, even in children, muscle use, which can all, further cause low food intake and cachexia. Eating food, especially in our culture, has utmost importance to the patient and the family. It is cultural, emotional, and religious significance, and the inability to enjoy food can affect the entire family practically. So we have so many parents who come to us saying that we haven't had food since 7 days because the child has not had anything. And then we have parents who then present with hypoglycemia. Some of them faint in our OPD. Some of them are just do not want to eat anything because the child has not eaten anything. And sometimes the belief is that if the child eats something, the child will again get healthy, and maybe the child will be able to tolerate chemotherapy more, and then they can give chemotherapy, and they are not giving chemotherapy because the child is weak now, because the child is not having. So it's a vicious cycle that we need to address and break the cycle. So anorexia is most common side effect of treatment, can lead to poor caloric intake. It's reversible in initial stages. Later, when the child does not take any cancer-directed treatment, it's usually not reversible. Cachexia correlates with prognosis actually in cancer. It's generally a cluster of symptoms. How do you assess? So there are multiple things that you can do, but like ma'am said, and we've discussed, that you do not go aggressive. So you'll not do a CT scan actually to assess how much fat or muscle mass the child has. You will not do that. So it's usually clinically that you do. And we focus on a lot of the contributing factors like fatigue, pain, dyspnea, infection, which can lead to weight loss. Principles of managing, you find out if there is something that can be reversed. In later stages, you actually focus on patient's comfort and reducing the parents and the family's anxiety. It has to be an interdisciplinary team, so you can involve your dietitians because they'll trust them more when it comes to nutrition, your occupational therapist, physiotherapist, pharmacist, speech language therapist if the child is not able to eat because the child has medulloblastoma or something like that. So you can involve your speech following therapist. And sometimes spiritual leaders and someone they actually trust and believe in. If you are able to involve them, the family may be able to understand better. You need to also acknowledge the distress about body image. This is very significant in adolescent kids. Not just adolescents, we have sometimes seen body image issues in kids as young as 6 to 7 years of age. So body image is significant now in the era of Instagram and all the social medias, where even the children are on Instagram and they are very conscious about how they look and how they appear. So body image issue because of cachexia is significant. And you need to establish realistic goal. The child is not going to gain 3 or 4 kgs if you're even going to feed them 1 kilo of ghee. So realistic goals are something that we try to set as soon as in the first presentation itself, to avoid any false hope. I'll not go into this detail because we don't have time. Some pharmacological management that you can use for anorexia, cachexia. Most of the studies are done in adult. I could not really find any study done in pediatrics. So these are extrapolated drugs that we use. So steroid and megestrol acetate. Steroid because most of the factors like cancer-induced anorexia, cachexia is inflammatory cytokine driven. So dexamethasone really helps well. So small dose of dexamethasone will help in anorexia, cachexia. It will help in nausea, vomiting. It will help in fatigue. So it will improve the appetite. So you can consider short-term small dose of dexamethasone for the children to just as a trial method, but you will not continue it for a long term. Megestrol acetate, it's a prostaglandin analog, and it has worked really well in adult. However, has a lot of complications like deep vein thrombus. So not very regularly used in children. Rest of the medicines that you see here are not advised for children, but they are used in adults. Something that really has proven benefit is olanzapine. Again, it's not recommended for children, but like Dr. Marianne Mukherjee ma'am said, that sometimes it's not recommended because studies have not been done. So if it's matter of days or months, you can still consider giving olanzapine. It has multiple receptor profile and works at multiple level, right from anxiety, depression, nausea, vomiting, appetite stimulant. So you can consider low dose olanzapine after discussing with the family about risk and benefit. NSAIDs, since anti-inflammatory NSAIDs have been studied in adults, but has really not shown any good results. So you will not prescribe NSAID for anorexia, cachexia. So there is this 4-year-old child with medulloblastoma not responding to verbal commands or painful stimuli since 2 days, not taking any food or liquid orally. Family insists on IV fluid to improve weakness. What will you do?
Counsel the family to hold on.
Sometimes we say we'll counsel, but sometimes it's actually it's impossible. They'll not listen. They'll just tell you that they'll take it to some other doctor. Then how will you do? Obviously, first step
Then
is
we can
counseling.
put NJ tube feeding, madam.
Tube feeding.
TPN.
Will you advise tube feeding to it? Sorry.
Yeah, NJ tube we can put instead of putting IV fluid.
NG tube. Most of them are saying
TPN.
NG tube. So there is a debate between NG tube and IV fluid. counseling NG tube. We need to respect family's wish. Absolutely, Dr. Prashant. We need to respect family's wish. And the family clearly here is insisting on IV fluid. So we really don't know how much nasogastric or nasogastric tube feeding will benefit at this point. So she's not responding to even painful stimuli since 2 days, not taking anything orally. This might be end of life. And end of life, you don't want to put a nasogastric tube, especially when that is not the family's demand. So the family here is insisting on IV fluid. So what we can do is explain the family that this is probably end of life. The body does not require nutrition at this point. Urine output normally decreases. Artificial hydration nutrition is only going to worsen some of the symptoms here. And like Sir said, you need to respect family's wish. So you can consider giving trial of 24 to 48 hours. So you need to talk to the family beforehand that this is what we are going to try. We'll see if there is any improvement in any of the symptoms during the trial period. And if there is nothing, then we will not continue the IV fluids any further. So here you are doing what is right, at the same time respecting the family's wish also. Nasogastric tube is really a matter of debate. I don't know, if we ask, most of us are not very pro nasogastric tube because it can be distressing, especially in end of life when you know the child only has few days to live. Diarrhea, I'll not really talk about diarrhea because as you saw in the first slide, diarrhea is not very common, especially in end of life, and the management is not very different from what you would normally do. So the only thing that we need to understand that sometimes the patient may or the child may present with spurious diarrhea. So the child actually has severe constipation, fecal edema formation, and that's presenting as diarrhea, and we keep on giving all the medicines to stop diarrhea without doing a PR. So that is something that I would focus on. And some medication-induced diarrhea, so chemotherapy-induced and radiation-induced tenesmus and diarrhea. So that time the management changes. So again, like antibiotic is not for everyone. If it's radiation-induced diarrhea, or if it's chemotherapy-induced diarrhea, which is just secretory diarrhea, not the child is not neutropenic, child does not really have fever, you don't need to give antibiotic every time, especially during end of life. What we need to actually treat is the dehydration that is causing the symptoms. So yeah, take-home message is the same as Dr. Mukherjee has already said. These are our acknowledgements. Thank you. So we have some around 7-8 minutes for discussion. If you have any questions.
Thanks, Dr. Shalmali and Dr. Marianne. That was a wonderful, comprehensive discussion. There haven't been too many, whatever questions that have been in the chat have already been sort of taken up as we went. But if there was a discussion about PEG somewhere, in a situation with end of life, I don't think PEG would be a very good idea. But if there are any other sort of comments or questions, you are welcome. Maybe if all the participants can turn on their cameras, we can all sort of have something similar to a face-to-face discussion.
Did you just talk 1 minute on subcutaneous, no? Because they may not be aware of subcutaneous unless it's in some other lecture, I don't know.
Right. So we may have another lecture on IV on nutrition in general, but just to talk about subcutaneous administration of fluids, Shamli also touched upon it a little bit. Yes, Dr. Chandra, we will share the slides via email. So subcutaneous is usually in the last few days to weeks of life a preferred alternative to IV. or if enteral is not a possibility, rather oral medication or oral feeding is not a possibility. Many a times, if the child is having because of any reason unable to take oral medications, the child will be dehydrated. Getting IV is going to be very difficult. And so if we are looking at administering, say, 2 or 3 medications, or if we need a little bit of fluid hydration, then subcut is a preferable route. Subcut is usually given, we can either use a scalp vein, or we can use a 23 gauge or a 26 gauge IV cannula. So the yellow one or the blue one. And instead of inserting in the method of insertion is the same. It's just that instead of inserting in the vein, we are just inserting it under the skin. So whatever administration is happening via the subcutaneous route. So whatever absorption is happening via the subcutaneous route. Most medications are most medications, especially the ones that we need to give towards the end of life, are able to be given by subcutaneous routes. So opioids can be given, IV fluids can be given, sedatives like midazolam, etc., can be given. Most of these are easily given via the subcutaneous route. Now, sometimes there is a dilemma about how within subcutaneous route is it really possible to give IV fluids? But yes, it is, because what literature shows is that it's actually possible to give about, in adults at least, it's possible to actually give about 500 ml within about, say, 40 minutes to an hour, and easy resorption or easy kind of absorption is happening. So the same applies to children, but obviously we will give for body weight in their case. So this is a little bit about subcutaneous. Okay, Dr. Subramaniam is saying, can you share some articles for reading on subcutaneous fluids? We'll search for some and we'll give them to Vanilla to send them forward. That's great. I don't think that there are too many questions. So, Dr. Marian, would you like to sort of just say a few final words?
No, I think it's really nice that people are writing so much in the chat, because even though it's such a great group, it shows that they are actually listening to us. Wonderful. I mean, I'm sure if you all had any questions, even later, after you maybe want to talk, kind of think about what we have spoken, we are more than happy to clear those doubts, because the whole idea of these sessions is you all have so much of knowledge, but maybe you need to just rethink quality of life and quality of death, and then see that some of those interventions, are they really improving the quality of life and death, or are they actually making it worse? That's it. Thank you.
There is a question about how are we going to ask a child's perspective about dyspnea? I think what she's trying to ask is, how will we ask a child to explain their dyspnea?
Yeah, so that's why I think those two, especially the Dalhousie scale, is very pictorial, and it does help sometimes. But one also just needs to kind of spend enough time with the child to understand how it is affecting their concept of how their life is going. And once you've kind of understood the specific points which are affecting which are being affected. I want to go to school, but I can't. I want to play cricket, but I can't. So it's kind of trying to understand those questions, that what is actually the hurdle for them, and then trying to think about, with the help of the parents and friends and anybody else, how can we change this? So it's very subjective. I think both the symptom and the management are very subjective.
Okay, that's great. So thanks a lot for joining, everyone. And thanks again, Dr. Mary and Dr. Shamali. Keep the interaction going on. I'm requesting this to all the members. It's very heartening to be able to have a lively discussion, and we are also able to know better how to focus, what to focus our kind of next efforts on.
But in the future, I think it would be really nice for the lecturers if you guys kept your cameras on, because when I first started talking, there wasn't a single camera except Shamli's and mine. So we wonder whether y'all are, how much you're actually, kind of listening to us. So please, for the future lectures coming, please keep your cameras on.
Thanks, everyone, and we'll see you next Saturday. Bye.
Thank you, everyone. Thank you, ma'am. Thank you, Smriti, ma'am.
Bye.
Thank you.
Bye. Bye.